بسم الله الرحمن الرحيم. طبعا اتس جريت اونر ان ابقى مدعو في المؤتمر الديستنجويشد اللي احنا بننتظره كل سنه، مؤتمر الهايبرتنشن. استاذ دكتور محسن، استاذ دكتور سليمان، استاذ دكتور عمر عواد، دكتور وفاء العروسي، والزملاء الكتير قايمين بدور قوي جدا جدا في الاويرنس اوف ذا بلاد بريشر ريسك اند مانجمنت. It's a great honor also to introduce Professor وليد عمار صديقي الغالي وكو-تشيرمان دكتور أحمد الغليظ to introduce a very important subject, heart failure sliding doors when right and the early treatment are crucial. دكتور وليد عمار.
بسم الله الرحمن الرحيم. Thank you very much my dear friend and colleague Professor Ahmed for kind introduction. بشكر طبعا الجمعيه المصريه لضغط الدم على الدعوه الكريمه وشركه سانوفي اللي ادتني فرصه اقابل حضراتكم النهارده to discuss the following 15 to 20 minutes a very important topic to prevent and treat heart failure. In this presentation, we'll try to go through a real life case of a patient journey. And during the presentation, we'll discuss how to prevent, how to diagnose, how to prevent complications of heart failure in our patient. Our patient has been transferred by the ambulance to hospital because he developed severe dyspnea and palpitation. Going back to his history, he's a 50-year-old, he's hypertensive, he's diabetic, he's a smoker, and he presented with severe shortness of breath. On arriving at the ER, our patient has an elevated jugular venous distension. He has lower limb edema, positive RELs on auscultation. We have evidence of pulmonary congestion on a chest X-ray. His blood pressure was not controlled, as you can see, neither heart rate, 1.5, and we have ECG evidence of left ventricular hypertrophy. Other chest conditions are excluded that may cause this shortness of breath. Therefore, we have a case of suspected acute heart failure who presented to the ER. After taking a good history, proper physical examination, we have to conduct the baseline lab and imaging workup, including electrocardiogram, pulse oximetry, baseline echo, chest X-ray, and lung ultrasound is very helpful available to detect pulmonary congestion and effusion. If we have natriuretic peptide as the initial workup, it is very helpful to roll in or roll out the presence of acute heart failure. We have a cutoff points for acute heart failure that are different from a chronic heart failure. For acute heart failure, we need a PNB above 100 or any terminal pro-PNB above 300. To a large extent, if the patient have normal PNB or any terminal pro-NB, you can roll out acute heart failure, at least in 80% of cases. Going back to our patient, he was on DDB4, metformin for diabetes control. He was on amlodipine for hypertension and atorvastatin 20. However, his lab workup showed he was not controlled either regarding diabetes. A1C was 8. He has significant proteinuria, 200 milligrams, and his LDL target was 110 on rosuvastatin. Therefore, he was not reached his targets regarding blood pressure, glycemic control, or lipid control, or proteinuria for renal protection. On echo, I had evidence of left ventricular hypertrophy when ejection fraction is preserved at 52 and significantly elevated natriuretic peptide. Our patients 3 months before presentation had gradually progressive shortness of breath. However, when he visited his treating physician based on a preserved ejection fraction, he was not considered as a case of heart failure. However, if you look at the universal definition and the classification of heart failure based on ejection fraction, we have 3 main types. We have HFrEF, which is ejection fraction below 40, and the mildly reduced ejection fraction from 40 to 50, and we have the heart failure with preserved ejection fraction in which we have a baseline ejection fraction above 50. And we have a fourth type, which is improved ejection fraction, heart failure with improved ejection fraction. These are patients with a baseline ejection fraction below 40 that have been increased with treatment by 10 points, and now it exceeded 40% an ejection fraction. The importance of differentiating HFpEF from HFrEF is important because it is prevalent. 50% of our patients with heart failure may have HFpEF. These patients are not at low risk. They have similar hospitalization rates, similar in hospital complications rates, and also, as you can see from this figure, they have similar survival and mortality rates. Heart failure is a global pandemic, and the event of heart failure hospitalization, like our patients, is a very important step in his journey, because once a patient with heart failure is hospitalized, is at high risk for rehospitalization 25% after 1 month, 50% rehospitalization after 6 months, and mortality may reach up to 50% after 5 years. And the mortality rate with heart failure may exclude several types of cancer. Heart failure with preserved ejection fraction is presented up to 50%. And usually these patients have a lot of comorbidities like diabetes, hypertension, CKD, atrial fibrillation, and obesity. Elevated natriuretic peptides is present in 80%. Therefore, 20% may have normal natriuretic peptides, like for obese patients. Outcome are comparable, as I said. Therefore, it's very important to prevent development of heart failure with a HIF of HIF to decrease mortality and morbidity of our patients. What could have been done earlier for our patients with uncontrolled hypertension, uncontrolled diabetes to prevent this heart failure progression? If we went back to guidelines for diabetes and pre-diabetes and to prevent cardiovascular disease, we'll find that patients who are admitted in registries or trials without evidence of clinically manifest heart failure may have up to 28% unmasked heart failure. And the majority of this heart failure are heart failure with preserved ejection fraction more than 80%. Therefore, diabetic patients without known history of heart failure, if we examine him thoroughly, he will find that about 28% will have heart failure and impaired ejection fraction or diastolic dysfunction, fulfilling criteria for heart failure with preserved ejection fraction. Early cardiovascular risk assessment is crucial for our patients with diabetes. And the very step for a patient with diabetes, type 2 diabetes, for example, is to exclude the presence of associated atherosclerotic cardiovascular disease or target organ damage. Our patients, if you remember, he has left ventricular hypertrophy and he has proteinuria. Therefore, our patient has evidence of target organ damage. If this patient has this evidence of target organ damage, he is considered a very high risk. In absence of target organ damage or established cardiovascular disease, we do a risk assessment and we have a new score, which is a score 2 diabetes score for such patients. According to the score, we can classify patients into high risk, intermediate risk, or low risk. Based on the risk category of our diabetic patients, we try to decide which treatment will be very beneficial. In patients on the right hand, which are extremely risky patients with diabetes, with target organ damage or evidence of atherosclerotic disease, SGLT2 inhibitors and GLP-1 receptor agonists are class 1 recommendations to prevent and treat associated cardiovascular disease. And the lower risk the patients with low risk or intermediate risk, in these patients you can use metformin, and the intermediate you can use either of them with a lower evidence for benefit. Therefore, it is important to give the right treatment to the right patient at the right time. SGLT2 inhibitors and GLP-1 receptor antagonists are recommended to reduce cardiovascular risk independent of the glucose control, and it's very important. Now we have a treatment for primary prevention of cardiovascular disease like SGLT2 inhibitors. For patients with diabetes, with or without heart failure, it's class 1 recommendation to switch to glucose-lowering treatments from agents without a proven benefit. Patients on DD4 or sulfonylurea, it's better to shift these patients to SGLT2 inhibitors or GLP-1 receptor agonists, especially patients with baseline atherosclerotic cardiovascular risk factors or established cardiovascular disease. It's class 1 recommendation to start such patients if no contraindication with a drug like dapagliflozin. Our patients was only on DD4 and metformin, which is not the proper treatment for patients. Why is this evidence for dapagliflozin for primary prevention of cardiovascular disease? This came from the DECLARE TIMI trial. In this patients with type 2 diabetes with established disease or multiple cardiovascular risk factors were treated with dapagliflozin versus placebo. Initially to assess the safety of adding a new antidiabetic drug. But at the end of the trial, we found that dapagliflozin compared to placebo was associated with an 18% relative risk reduction of heart failure hospitalization and cardiovascular death. Therefore, it was recommended by all the societies that SGLT2 inhibitors like dapagliflozin are very helpful in patients with type 2 diabetes and the cardiovascular risk factors to prevent combined endpoint of heart failure, hospitalization, and mortality. What could have been done earlier considering the early diagnosis of HFpEF? This patient was symptomatic over the past 3 months, but based on a normal ejection fraction, he was not considered heart failure patient. And also had hypertension that was managed only with amlodipine and was not controlled. Hypertension is very important as diabetes. It's by far the most frequent precursor of comorbidities in patients with HFpEF. ولما اتعمل سكور اللي احنا نشخص بيه الهيف بيف بانه not easily diagnosed زي ال H2 FBF score لان الهايبرتنشن can come on the top of the list. The patients based on this score may have a low or high probability of having HFpEF. And this score for H for obesity, hypertension, atrial fibrillation, very important, it takes 3 points. Pulmonary hypertension, elderly population above 60, and abnormal filling pressure with an abnormal E over E prime above 9. Our patients, of course, fulfill the criteria of heart failure with preserved ejection fraction. The focused update on heart failure treatment that was published last year. We know before that up to last year, we did not have any class 1 recommendation for treatment of heart failure with preserved or mild reduced ejection fraction, apart from fluid control with diuretics to relieve pulmonary congestion. All the medications with class 2B recommendation, including ARNI, ARPs, ACE inhibitors, beta blockers, and mineralocorticoid antagonists. But after the liver and empagliflozin and dapagliflozin trials, they were recruited in the guidelines as class 1 recommendation. Now we have a proof of evidence that in patients with heart failure with preserved ejection fraction, we can add dapagliflozin as a class 1 recommendation to decrease the combined endpoint of mortality and heart failure hospitalization. And the data come from the liver trial. Patients with preserved ejection fraction and the high N-terminal pro-BNP, they have heart failure with preserved ejection fraction. Compared to placebo, on top of all medications, we have at least 18% relative risk reduction of the composite endpoints of heart failure, hospitalization, and mortality. What about treatment of hypertension? We know that hypertension is a main precursor of HFpEF, and our patient was not controlled. The target of blood pressure control in the general population is 140/90, and the same applies for patients with HFpEF. But if we can go lower to 130/80 and well tolerated, this is a better target than 140/90. And this is a recommendation from the European Society of Hypertension in patients with hypertension and the HFpEF, heart failure plus hypertension. Again, stepwise approach. You start with ACE inhibitor, CCP, and diuretic, whether thiazide or thiazide-like diuretic. But it is equally important to add SGLT2 inhibitors because our patients have evidence of HFpEF, regardless of presence or absence or diabetes mellitus. If not controlled, you add another medication for heart failure control and for blood pressure control. ARNI may be used as an alternative for an ACE inhibitor based on data extracted from Paragon heart failure trial, because some patients may have benefit from sacubitril valsartan, especially with lower margins of ejection fraction. As you can see, you start your treatment for hypertension and HFpEF with an ACE inhibitor like ramipril, and you add SGLT2 inhibitor like dapagliflozin in such patients. It's a class 1 recommendation. We have a combination of ramipril and diuretics, and it was tested for control of blood pressure in Astral trial for study. These patients, 500 patients, subjected to a combination of ramipril plus thiazide, and after 8 weeks, we have a very good response with a good reduction of systolic by 31 and diastolic by 18 millimeter mercury, and the compliance rate exceeded 90%. Of course, single pill combination have a good response and better compliance rather than a single pill combination. And the HOPE study, which is a cornerstone, a groundbreaking trial in history of ACE inhibitors more than 20 years ago. Patients at risk for cardiovascular events received ramipril up to 10 milligrams compared to placebo in 10,000 patients, multi-center placebo-controlled trial, well conducted. And at the end of the trial, ramipril compared to placebo was associated with 23% reduction of heart failure. Therefore, in patients without heart failure, if we started treatment with ramipril after 5 years, we have significant reduction of new development of heart failure. The same applied for dapagliflozin for type 2 diabetes. Therefore, our patients with a baseline diabetes and hypertension, if our patient was kept on a good dose of ramipril and dapagliflozin, we may prevent the progression to heart failure. Ramipril also have a very good evidence in patients after acute myocardial infarction complicated by impaired ejection fraction. The IR study for patients with MI complicated with impaired ejection fraction, and the extended study from IR after long-term follow-up up to 6 years. At the end of the IR and the IRX trial, we have 36% reduction in mortality, better survival with ramipril compared to placebo. We have very effective medication. To the extent that ARNI compared to ramipril after complicated myocardial infarction, patients who sustained myocardial infarction with a poor ejection fraction below 40 and the additional risk factors like age above 70, atrial fibrillation, diabetes, prior MI. These patients were randomized to ramipril versus sacubitril valsartan to look for the next endpoints for mortality and heart failure, hospitalization, development of heart failure. As you can see, ramipril was non-inferior to sacubitril valsartan. They did the same. Therefore, in patients with recent heart failure after myocardial infarction, there is no superiority of ARNI, sacubitril valsartan, over ramipril. Ramipril, of course, in another trials like SAVE, IR, and TRACE, were very effective compared to placebo, but we have evidence they are equally effective as ARNI as well in such patients. What about dyslipidemia, the last comorbidity in our patient? Our patient is considered a very high risk because he has evidence of target organ damage, he has comorbidities, he has risk factors like hypertension and diabetes. Therefore, our patients come on the very high risk patients in which his LDL target is 50% reduction from the baseline and the achievement of a target LDL below 55. Our patient has an LDL of 110. Therefore, he was not controlled. We have to change or upgrade his LDL lowering medications. In conclusion, our patients, and according to all the guidelines, whether it's hypertension, diabetes, heart failure, or the American Diabetes Association, the goals of diabetes control of our patients is, of course, the glycemic control, in addition to weight management. But look at the cardiovascular risk factors and the cardiorenal protection. You have to start medications with proven efficacy in prevention of heart failure and cardiovascular endpoints and renal protection. Our patient has diabetes, hypertension, and diabetes. He was not properly treated, therefore he developed aggressive form of heart failure with preserved ejection fraction. If we can treat this patient from the early beginning with the good tools, we may prevent this heart failure. And during hospital admission, this patient needs early initiation of all guideline-directed medical therapy with rapid up titration. At this way, we can prevent rehospitalization and we may prevent mortalities. And after patient discharge on outpatient basis, proper treatment of stabilized heart failure with good medications like dapagliflozin, ramipril, proper control of heart failure, hypertension, dyslipidemia may prevent further events like mortality and rehospitalization. And thank you very much.
Thank you very much وليد. حقيقة يعني سهل الممتنع وكله مفهوم تماما. Any question؟ طيب ألف شكر ليك يا وليد. واحنا كوفي بريك فور بس ربع ساعة علشان نلحق نكمل البرنامج بتاعنا. شكرا. أشكرك.